We're back.
We are.
Took a month off.
And we...
A lot happened in that month that we took off, which when we first decided to take that month off,
oh boy,
that was not, like, none of that shit had happened. So that was not really part of that conversation.
No. When is it gonna end?
But I'm sure glad we took that month off now.
Incoming broadcast. You're listening to .fm.
Welcome to .fm. I'm your host, Danielle Gonzalez.
I'm Claire. I'm my own best audience, you know?
Well, sure.
Anyway, what are we talking about today?
Today we're doing a fun episode. This is an episode you've been wanting us to do.
Yeah.
We're talking about the history of gender-affirming care.
Excellent. Excellent. There's a history of trans voice too that I like to draw some inspiration from in the TikTok. So I'm really excited to learn more about like gender-affirming care. I think like just generally like, you know, gender-affirming care has looked differently throughout like the world. It's not just been medical. And so like there's also therapy to consider, you know, like what that looks like. Anyway, I'm just really excited to learn more about it because it's an area that I don't know much about. Ask me about voice, I'll tell you all about it. Ask me about gender affirming care. Well, let's learn together, audience.
Well, and that's a great segue to kind of go into this brief disclaimer that I want to bring in at the top of the episode, which is that two things. One, I mean, the concept of gender affirming care, like you said, is pretty large and all encompassing. Mm-hmm. So more specifically, this is like gender affirming medicine in today's episode.
Okay.
And then the other part of that is that the study of gender affirming medicine and gender affirming healthcare is still kind of in its infancy. We're still, you know, kind of discovering a lot. There's a lot of research that needs to be done, a lot of further study. So take everything in this episode kind of with a grain of salt, knowing that we're not going to be covering everything because there's, you know, too much to go into all the details right now. And also there's still a lot more to discover.
But Danny, I thought we were not supposed to study anything and just make assumptions on facts that we want to be true.
No, see, that's how you get into like myths and things.
Like conspiracy. Oh, that's right. Oh.
Speaking of, we should probably do a little bit of myth busting right here at the beginning.
Oh, yeah.
I think right now the conversation around gender affirming healthcare, there's a lot of myths floating around. There's a lot of, you know, misinformation, different ideas, people talking about things that they don't really understand. So we should probably make sure that everyone is on the same page and bust some myths. So let's do that right now, shall we?
Yep. Mythbusters. Puberty blockers are new and experimental.
Yeah, so that's not actually true. In fact, puberty blockers were approved by the FDA in 1993, and they've actually been used for decades to treat precocious puberty in cis folks, cis adolescents, as well as, you know, any number of other conditions. Long-term studies of the long-term effects of puberty blockers have been happening, and they show that children who receive puberty blockers are, you know, totally normal fertility, normal reproductive function as adults.
Nice.
It's not new. It's not experimental at all.
I actually didn't know that. Like, I was never sure about that. Like, if puberty blockers caused any sort of reproductive issues as adults. And that's cool. Now I know. Now I can actually have a more elegant conversation with my students about these things.
Yeah.
So,
and
nice.
We get into like some of the history of puberty blockers and all that stuff later in today's episode. But yeah, they're not nearly as new or experimental as people think they are. They're just new to the conversation, I guess. But they've been around for at least 30 years. So what's our next myth, Claire?
So gender-affirming care is entirely dependent on the whims of individual care providers and totally experimental.
Also false.
What?
That's kind of the whole point of this entire episode. But in fact, gender-affirming care has already been standardized in the U.S. since the 70s under the World Professional Association for Transgender Health, also known as WPATH. We'll talk more about all of that later, but it follows a standardized set of evidence-based guidelines that is called the Standards of Care, or the SOC, for the health of trans and gender diverse people, which is now currently in its 8th version.
Hell yeah.
So kind of like how the DSM for mental health, there is a version for trans health that has existed since the 70s.
Cool.
And it's built off of decades, if not centuries, of research.
Yeah, but Dany, aren't children subjected to irreversible changes like surgeries?
I see you're jumping into our third myth. No. So according to the WPATH standards of care, minors are only recommended social transition. Things like changing their clothes, their hairstyle, name, pronouns. All of that stuff is completely reversible if the child changes their mind. Puberty blockers might be prescribed if the caregiver and parent think that it's necessary. Again, puberty blockers are 100% reversible. We've known this for at least 30 years, if not longer. Surgical procedures are only recommended for ages 18 and older, and there are a lot of guidelines that a lot of hoops patients have to jump through in order to access those surgeries.
Yep.
So there are no children receiving bottom surgery or top surgery. So
I think also, that kids are being trans.
Trendy.
No, yeah, being trans is infectious. Everybody wants to be trans nowadays, Dany. It's so cool. It's so trendy.
No, I'm going to call bullshit on that one too.
Oh, okay. Yeah.
And in fact, we have a really good historical example of a similar social phenomenon. Have you ever heard about the history of left-handedness in the United States?
I have. In the history of left-handedness, everyone thought it was a bad thing. But then the second that people started accepting the idea that people are left-handed, there was a huge surge of left-handedness is being reported in the United States.
Exactly.
Yep.
Yeah. I mean, prior to I think it was the 1910s or something like that, all children were taught to be right-handed, whether they were right-handed or not. Mm-hmm. And there was a religious stigma that people who were left-handed were evil or closer to Satan. And then there was a kind of tangentially related social stigma that people who were left-handed were clumsy. We know where both of these things come from. The whole religious stigma stems from this, Jesus sits on the right hand of God, and so right-handedness is closer to godliness or whatever.
Wild.
And then the clumsiness thing is purely just from the history of how we design things. In the Industrial Revolution, when more and more machines were being made for factories, they were typically designed for right-handed use. So people that tried to operate them with their left hand had a slightly harder time doing it. And it created this artificial perception, this, sort of stereotype that left-handed folks were clumsier. And it was just because they weren't designed for left-handed use, and it reinforced this concept that we need to teach our children to be right-handed. But the second we stopped forcing right-handedness on kids in schools and started allowing people to just be left-handed, people started identifying as left-handed. They stopped forcing themselves to be right-handed. We see the exact same thing with being, queer or trans. As we learn more about it, as we make it more acceptable to be these things, people stop having to hide who they are. They stop having to deny, who they are, and they're able to be more out and open about it. So, purely on a graph, it looks like you're catching it like it's infectious. But
Dany, won't people end up being left-handed? I mean, transgender?
These are really good segues. This is really nice. No, actually, it only in studies that we've taken of trans folks and detransitioners, only about 1% of people who transition ever detransition. And when we survey the people who do detransition, most of them report that the reason that they detransitioned is due to social pressures, such as being disowned or evicted or fired from their job, not regret. The actual true number of regret is something like 0.1%, which is wild.
Yep.
The regret rate for bottom surgery for trans women, I think, is 1.5%. Do you know what the average regret rate is for knee surgery.
Isn't it like 20% or something?
It's like 16%.
Wow.
So like trans folks have a regret rate less than like other medical procedures and elective surgeries. The regret rate for elective cosmetic like breast augmentation is like 34%.
Wow.
Which, kind of tying that back to children, with a parent's consent, a 16-year-old girl can have breast augmentation.
That's insane.
It is insane.
Wild. Are you saying to me that a 16-year-old girl can have gender-affirming care?
Bingo. So gender-affirming care is not just for trans people. That's the thing that I think people forget the most. So when we talk about gender-affirming care, we're talking about things that, yes, trans people need access to, like hormone replacement therapy and bottom surgery and breast augmentation and, you know, laser hair removal and all that kind of stuff. But those aren't not things that only trans people access. We see gender affirming care for cis folks all the time. If you're male and worried about male pattern baldness, and so you start like finasteride, that's gender affirming care. Or if you're a cis woman who wants breast reduction for any number of reasons, that's gender affirming care. Or breast augmentation for cis women, gender affirming care. Like, you see how this happens? And as we go through the history, you're going to see that like a lot of the history comes not from a need to help trans people, but a need to help cis folks. And then those are just applicable to trans people also. All right, all that out of the way. Whew. Let's get into the actual history.
Excellent. I'm ready. Take notes.
There will be a test. To start, we're going to start as early as I could find it, but it's important to know that, like any form of medical science, gender-affirming care is built upon layers and layers and layers of discoveries. Oftentimes, these medical procedures that we use for gender-affirming care, like we mentioned, they're originally discovered for treatment of completely unrelated conditions in cis folks. An example of this, the modern orchiectomy, the removal of testicles, dates all the way back to surgical castration for eunuchs. And we're talking like all the way back, like
Wow.
4,000 BC, if not older.
I was going to say the castrati, which is a...
Well, yeah, I mean, castrati is a type of eunuch, specifically
for the choir, yeah.
Yes. So we see this kind of all over the place where it's not specifically related to, you know, trans identities and trans healthcare, but it is applicable. There's a medical treatise written by Hippocrates around 2,500 years ago, I think, like 500 BC. In it, there's a record of Scythian eunuchs that he talks about performing female work and speaking like women in this text. So I believe the text was called On Airs, Waters, and Places, written by Hippocrates. In On Airs, Waters, and Places, Hippocrates talks about gender nonconformity among the Scythians, and, you know, he speculates on the different origin and nature of this nonconformity. In this particular case, he speculates that the effeminacy, as he calls it, associated with impotence and excessive horse riding. Men who ride horses too much eventually become effeminate. God. But he does also talk about how there are just people among the Scythians who are just gender non-conforming, and that perhaps because they might be gay or what we might consider to be a trans woman now, they perhaps were punished, and that punishment was castration. But we do see that there is this sort of history of these sort of surgical techniques of sorts.
Sure.
Granted, they're not good. Like, I'm not sure that like the success rate for these was particularly high.
Yeah.
But we do see that this kind of happens. However, what is kind of interesting is there is a record of what appears to be the first recorded example of gender affirming surgery all the way back in an ancient Greek record that comes back from an ancient Greek historian. Now remember, when we did our episode about Sappho, we talked about ancient Greek historians, and I had to remind you and the audience that we're not talking about historians that are experts on ancient Greece. We're talking about historians who lived in ancient
That's
Greece.
right. Yep.
So, and this historian's name was Diodorus Siculus. He writes of two intersex individuals. Both of these folks were born in the 2nd century BCE. They were both assigned female at birth. They were raised as women, both married men. And at some point, they underwent surgical procedures for what healers thought initially were tumors, but it ended up being that they had found some not fully developed masculinized genitalia, you know, an intersex condition.
Yep.
And one of the patients, Callan of Epidaurus was his name, the surgeon crafted a urinary meatus on what had been an imperforate glans penis, is the medical
Wild
term, basically rerouting the urethra to what was a not fully formed phallus.
This is ancient Greece.
This is ancient Greece. This is like 200 BC. The other patient, Diophantus of Abe, they performed a sort of cosmetic surgery to mold the genitalia into a more typical masculine shape. And both of these trans men lived their lives as men after these procedures. And, you know, Diophantus later even joined the military and saw battle. So we do see some of these things all the way back in history.
Talking about like surgical stuff always makes me so squeamish. Like I remember when I was a kid and like someone would talk about like, oh yeah, I broke my arm skateboarding or whatever. And like my arm would start to hurt. Like talking
That's
about
called sympathetic pain.
Oh, okay. Talking about anything surgical just like makes me feel like all sorts of like, oh, I don't know. So I'm excited to move past the ancient surgical techniques. I don't know about you, but
how about 7th century?
All right, we're moving on up.
In the 7th century, there's a Byzantine Greek physician named Paul of Aegina who described several surgical procedures to aid patients that struggled with, you know, sexual characteristics dissonant with their gender, I believe is the exact quote in his writings.
Poetic.
In his medical compendium, it's called, he described treatment for cisgender men that had gynecomastia, or, you know, excessive breast growth in men. He talked about surgical treatments for cisgender women that had clitoromegaly, which is just like excessive growth of the clitoris where it begins to sort of look kind of like a penis of sorts. He talks about these surgical procedures. While that's not what we might consider, you know, involving like transition, that's still gender affirming care, like we, you know, talked about earlier. So we see that this has long been accepted for cis folks. It just hasn't been accepted or accessible to trans folks.
Yeah.
Until very recently. But it's still very interesting to think that, like, you know, there were physicians in the 600s in the, you know, Aegean region studying this kind of stuff.
Yeah.
It's really kind of cool.
It's really unfair.
Unfair that it's acceptable for cis folks for centuries, but not us.
What the hell, you know?
Welcome to the human condition.
I know. It's, yeah. I'm like thinking about all this as, you know, as it goes back, and I'm trying to figure out how to like put it into words, but you know, like if you're assigned male at birth and you want to do something that makes you more masculine, and the same as for feminine stuff, like it's generally accepted. But like the second that you're like, I want to feel more feminine, I want to look more feminine, I want to do whatever, if you were assigned male at birth, it's like shunned. It doesn't make sense. Like,
I know, right?
It's, yeah. Anyway, what's next, Dany?
So when we talk about like ancient gender affirming care, I think the thing that comes to mind you brought up earlier is castration, eunuchs and all of that. The most practiced medical procedure throughout history that we now consider gender affirming care would be the orchiectomy, and kind of attached to that, the penectomy, or, you know, as it was historically referred to, castration. There's a first century Hellenistic Jewish philosopher named Philo of Alexandria, and he described transgender inhabitants of the early Roman Empire as, quote, expending every possible care on the outward adornment. They are not ashamed even to employ every device to change artificially their nature as men into women. Some of them, craving a complete transformation into women, have amputated their generative parts. So, you know, suggesting that some trans women throughout history may have resorted to full castration since that was what was available to them.
Yep.
orchiectomies were well practiced for centuries. They were usually used to produce eunuchs or punishment, or as like a sacred religious act, like a sacrifice of some kind. It was also well known to treat certain cancers and urological diseases that were hormone sensitive. For instance, prostate cancer. They knew of prostate cancer in ancient Greece and ancient Rome.
Wow.
And the way that they treated it, because it's a hormone sensitive cancer, is they would castrate, and you produce less testosterone, so it slows the growth of the prostate cancer.
Insane.
So it was a legitimate medical procedure in addition to being used as like a punishment. Mm-hmm. But they also used it on, like you mentioned, the castrati, young boys, prepubescent boys, to keep their voice from dropping so that they could continue to sing in a high register. It was used all over the place. And, there is record of trans women in ancient Rome attempting to access that procedure as gender-affirming care all the way back then. Mm-hmm. Surgeons have seemingly attempted to perform vaginal surgeries as well since ancient Greek times, but I'm pretty sure those were pretty much entirely on like cis women, still gender-affirming care, but to restore form and function of the vagina. There's descriptions of surgical attempts to correct everything from like an imperforate hymen to complete vaginal agenesis, which is like where the vagina doesn't form normally in human development. Mm-hmm. I believe, however, at least from everything that I was able to find, most attempted procedures were just unsuccessful. Yeah. In fact, the first recorded procedure to create a full vaginal canal wasn't until 1872. Wow. And that was still in a cisgender woman.
Did you learn anything about, is it phalloplasty?
Phalloplasty. Not anything super specific. I mean, earlier when we talked about those second century trans men, like they experienced sort of a rudimentary version of phalloplasty, but I didn't see anything too specific on like, specific procedures. And we're not going to go into like super specific procedures today. There are a lot of different, techniques that, it's way too much that we can get into today. But this first vaginoplasty in 1872 kind of represented a huge advancement in gender-affirming medicine for women and trans women. But prior to the 1900s, there were very few medical or surgical procedures that ended up being successful. A lot of that, I think, is just, because medical, surgical, physiological, pharmacological knowledge was very rudimentary in comparison to what we have today. So
people weren't washing their hands before surgery until like the 1800s or something.
Right. Yeah. So that's exactly what we're talking about. When we talk about gender affirming care, we went through a history of like some of the medical, history that we know of. But honestly, most gender affirming care was almost entirely social. And there's a much more documented history of like social transition and social care for trans folks throughout history than there is like medical and surgical intervention. Yeah. And I think it's for this reason. It usually wasn't successful.
This episode of .fm is supported by our Patreon because we are queer, independent, and, that's right, underfunded. If you like what we do and you want to keep it going, throw a coin to your trans podcaster.
Wait, is that still a thing? To throw a coin meme?
Yeah, I mean, I don't know. Wait, what year is it?
Patreon.com/.fem. That's patreon.com/DOTFEMME.
Reacquiring signal.
Modern history is kind of where things really begin to accelerate. We see huge interest in the exploration of like trans and gender diverse identities in larger society in the late
newfangled
1800s.
Thing. That's new, exciting.
That's right. So there's a German journalist and jurist, Karl Ulrichs, gives one of the earliest allusions to trans people in the modern age. He first mentions the idea of, quote, a feminine soul enclosed in a male body back in 1868. Obviously, trans people existed before 1868, but I think this is the first time that, it was in modern history we see it like documented in like a scientific way, wanting to actually explore this. And then, we get to the early 20th century with Dr. Magnus Hirschfeld. He creates the Institute for Sexual Science, performs the earliest recorded gender-affirming surgeries in 1922 on a patient named Dora Richter. She underwent an orchiectomy in 1922 and later underwent a penectomy and a vaginoplasty in 1931. She was the very first. We're not going to go into a whole lot of detail about Dr. Hirschfeld. For, more details on him, we have an episode about him.
We do.
We then also see another really, influential, famous patient, Lily Elba.
Yep.
We'll talk all about her next episode.
Woo!
But just a little bit here, she's another patient from the Institute. She underwent an orchiectomy, a penectomy, vaginoplasty. So she was, again, among the earliest recipients for gender-affirming surgeries. She also underwent the very first recorded uterine transplant in a trans woman, but that didn't go well. So more on all of that next episode. Also in the 1920s, we see effective pharmaceutical female sex hormonal medications first becoming available. One of the leading endocrinologists in Europe, Christian Hamburger, he's among the first to use what we would now call HRT or hormone replacement therapy as a means to treat gender dysphoria as early as the 1940s. But even 20 years before that, HRT was available commercially for menopause for, cis women.
Wow. So, that's huge. So we can actually draw almost like a date in which HRT began. That's really cool. 1940s, 1930s, maybe.
And even prior to the 70s, the, term HRT usually meant for post-menopausal hormone therapy. And even today, if you say HRT, a lot of doctors might be like, well, you're not menopausal. What are you talking about?
Right.
So it's been around for a while. Initially, HRT for trans women was done with high doses of estrogen, just straight up, here's a shit ton of estrogen. Hopefully it counteracts the testosterone kind of thing.
Yeah.
It wasn't until 1977 that anti-androgens like Cipro were first used, which allowed estrogen doses to be much lower, which is a good thing because high estrogen doses for trans women can lead to, blood clotting and other complications. So spironolactone, which is a drug that I think a lot of trans women our age would know, wasn't first used until 1986.
Wow.
But spironolactone, is interesting in and of itself because it was originally a diuretic. It was used to treat other urinary problems and help people, with bladder issues.
Right.
It was only later found that it also blocked testosterone and, androgen uptake. In some places today, however, high dose estrogen monotherapy is still used. Japan is a really good example of this.
Oh, interesting.
And we're still learning. We're still learning and adjusting. But in 1936, there's a Russian surgeon, Nikolai Bogoraz, I believe.
Nikolai Bogoraz.
And he performed the first total penile reconstruction using rib cartilage and a tubed abdominal flap. It was performed on, I think, a war veteran.
What?
A cis man
needed
penis reconstruction. But that technique was later used or adapted to be a gender-affirming phalloplasty performed in 1946 by Sir Harold Gillies on a fellow physician and trans man named Louis Michael Dillon.
That's cool.
Who I had not heard of until researching this episode. And in fact, Gillies' technique remained the standard one for decades. In fact, I think it's only in the last 20 or 30 years that some new techniques have kind of come about. In the late 40s, Dr. Alfred Kinsey releases the Kinsey Reports. He was a sexologist, kind of the American counterpart to Dr. Hirschfeld, but he founds the Kinsey Institute for Sex Research at Indiana University. His reports, he released 2 of them. They mostly comport with, sexual behavior of cis folks, but he did study, human sexuality on a spectrum as well as gender identity. He was one of the first researchers to use the term transsexual, in a clinical context.
Yeah.
1949, Dr. David O. Caldwell used the phrase psychopathia transsexualis to denote a desire for gender-affirming surgical care. obviously it's not the preferred terminology anymore.
Yeah, psychopathia, transsexuals, like
Yeah,
wild,
not ideal.
wild.
But it was a huge step forward in establishing just this, clinical idea that trans and gender diverse people were separate from gay folks, that they,
Right.
weren't just, extreme gays like people thought back then. It's different. Dr. Caldwell was very important in helping to kind of create what we now know as the established like sex, gender, and sexuality, as they exist as like separate and discrete entities, different things. Yep. So in the 50s, I think, is when things really begin to sort of kick off for gender affirming healthcare, at least here in the States. We see endocrinologist Harry Benjamin. He also studied under Magnus Hirschfeld. He kind of combined the ideas of social transition and medical transition like hormone therapy and referral for surgery as, this complete package treatment plan for individuals who were suffering from gender dysphoria. It wasn't called that at the time, but what we now know to be gender dysphoria. He published a book in 1966 called The Transsexual Phenomenon. It it became known as the Transsexual's Bible. It, kind of challenged this prevailing cultural idea about gender as well as the medical establishment of the time, and was really important for early, patients to have a successful transition. Chiefly among them in 1953, Christine Jorgensen, who was the very first American to undergo sexual reassignment surgery. She became a national sensation. She received hormone replacement therapy, orchiectomy, penectomy, all of that done in Europe by Dr. Christian Hamburger. And then she later received a vaginoplasty in the United States, supervised by Dr. Harry Benjamin.
Nice.
He was a huge figure in this. In 1969, the first international symposium on gender identity was held in London, and the first medical textbook on trans identity is published by Johns Hopkins University Press. And in fact, Johns Hopkins creates the very first gender-affirming healthcare clinic in the 70s. It was called the Johns Hopkins Gender Identity Clinic. It spurred a bunch of other centers to open across the United States, including the University of Minnesota, the University of Washington, Seattle. What? Stanford, University of California, Los Angeles, the University of Texas, Northwestern, and there were also facilities in the Netherlands and London that kind of followed this whole method. So this network, provided a safety net for doctors to provide surgeries without having to worry about criminal charges being levied against them.
That sounds familiar. Very
similar to what we're seeing around abortion right now.
Yeah.
So we were talking about puberty blockers all the way at the beginning of the episode. So in 1971...
What happened in 1971, Danny?
GnRHs, gonadotropin-releasing hormone agonists, which are what we now know as puberty blockers, are discovered.
Nice.
They're introduced for medical use in the 1980s for a variety of hormone-related conditions like uterine fibroids, endometriosis, also precocious puberty. That's why they're called puberty blockers. And they're also used for hormone-sensitive cancers like prostate and breast cancer.
Yay!
You don't have to get an orchiectomy anymore.
Woo! Gender affirming care, baby.
So when people talk about puberty blockers being new, they're not. They've been around for 50 years.
Yep.
And they were FDA approved for use in children to block puberty for 30 years. So they've been. We know what these do. We get it. It's not experimental at all. And like I mentioned, they're used for all kinds of hormone-related conditions.
And they're also used for other things as well, like, for example, Spiro, right? Which is a diuretic.
Right.
And it's like the side effect is reduced testosterone. There are thousands of men, cisgender men on Spiro. And like, are they, I mean, yes, they are getting tested for testosterone levels when they're on Spiro, but
yeah,
it's like it's safe. That's all I have to say.
Right. Well, and I think this just goes to show how blurry the line is between healthcare and gender-affirming healthcare.
Yep.
It's all healthcare.
Yep.
Right?
Yep.
The only thing that makes one, medical procedure gender-affirming is the intent behind it.
Right.
Like, just because the intent is different doesn't mean the science is suddenly experimental. Like, all of this is all based on, like, discoveries that, we've had for a while.
Yeah. Anyway.
In 1979, Dr. Benjamin, remember who we talked about, he oversaw Christine Jorgensen's transition. He established the Harry Benjamin International Gender Dysphoria Association.
That's it. Nailed it.
You sound like you're having a stroke.
It might be.
Thankfully, it was later renamed to the World Professional Association of Transgender Health, or WPATH, and they published their first standards of care in 1979.
Woo.
So that brings us to the WPATH era. In 1979, there were a bunch of studies that concluded that gender-affirming care improves mental health outcomes of gender-diverse individuals, that it's safe, it's effective, but high-level political and financial interests forced Johns Hopkins Gender Identity Clinic to close abruptly. And this kind of waterfalls across the country, and a lot of those gender identity clinics across the country close. It was kind of awful.
Yep.
And it's very similar to the sort of backlash we're seeing against trans folks and trans healthcare right now, right? In 1981, the United States Department of Health and Human Services issued a decision that labeled sex reassignment surgeries as experimental. All of them. Just all sex reassignment surgeries are experimental, which, you know, is kind of wild.
That's a wide
considering
net.
how we just went through the history, and a lot of the discoveries that proved that these were like successful and okay were done
affirming.
on cis folks.
Right.
Right?
But it's not experimental for cis folks, Danny.
Right.
It's affirming. Yeah. Yeah.
So DHHS issues this decision labeling sex reassignment surgeries as experimental, and it causes like all of these clinics to close all across the country. And it's really kind of like this one decision that stalled the progress and growth of gender affirming healthcare and research for the next 3 decades. Like literally like to now, like we're living through the ramifications of that decision.
Yep.
To this day. And it kind of forced trans patients to find alternate means of healthcare, including, you know, going underground, black market, you know, that kind of thing. It's really, really kind of dangerous.
We're still going black market. There's so many trans people all around the world.
We're starting to go back.
Yeah, there's so many who get their hormones on the black market.
Yeah. So the DHHS decision was overturned in 2014, which allowed, you know, Obamacare and the Affordable Care Act to cover gender affirming care.
Yep.
And, you know, under this current administration, they're talking about essentially not reinstating that decision, but making a new one that's basically the same thing. So it would once again push us right back into the underground. And we're already seeing people preemptively go underground because they can't access their healthcare. So it's you know, pretty devastating.
Yep.
In 1990, we'll go back to some puberty blockers because I feel like this is just really important right now. In 1990, Peggy Cohen-Ketnes develops what's called the Dutch Protocol. I don't know why it's called that, but it's called the Dutch Protocol. It's the first known example of using puberty blockers to treat gender dysphoria in children in 1990.
Yeah.
And a number of subsequent studies show that the treatment is fully reversible. As soon as you stop puberty blockers, puberty continues as normal.
Right, like we learned in the beginning.
Right. It shows that there's a great evidence for the overall positive outcome of children who are treated with puberty blockers. Yeah. It buys them time to, you know, figure out who they are and what they want to do. That's all it is.
Yeah.
So in 2011, the U.S. Institute of Medicine releases a groundbreaking report that highlights the need for additional research examining the health needs of the trans community. 2013, the American Psychiatric Association officially reclassifies transgender diagnosis as gender dysphoria instead of what it was previously called, which was gender identity disorder.
Yep.
So that, you know, changes the condition.
Well, it removes the disordered identity.
It highlights that, you know, the cause is not a disordered identity, it's a treatable distress, right?
Sure.
So an important distinction there, really, really cool. And that paves the way for the 2014 overturning of the 81 HHS decision that allowed gender affirming care to be covered by Medicaid and Medicare under the Affordable Care Act.
Which is how I got started.
Me too.
Like, I wouldn't have been able to afford HRT stuff without the 2014 overturn, right? Like, I mean, I transitioned in 2014, so.
I started hormone therapy in October of 2015. So actually, when this episode comes out, it'll be 10 years.
Woo!
which is why I wanted to do this episode now. But
Congrats.
yeah, I'm not sure I would have been able to access my HRT and definitely not any of my surgery without the Affordable Care Act.
No.
And then in 2017, Johns Hopkins University relaunches the Gender Identity Clinic under a new name, the Center for Transgender and Gender Expansive Health. So it's back. It's back, baby. Let's hope it hangs on.
I know. Seriously. Yeah.
But yeah, that kind of brings us to today. That's the history of gender-affirming care. So I guess, I mean, we talked a lot about, especially in this modern era, kind of WPATH, and we started the episode busting some myths. So I guess we should probably talk about like what the actual WPATH standard of care is for gender affirming treatment today. The current standard of care, SOC 8, does not specify an age at which to start medical or surgical intervention, because you never know when there's going to be some extreme fringe case that necessitates it. But what it does say is that puberty blockers are typically the first medical intervention recommended for youth to delay the onset or completion of puberty. It's specifically to allow patients more time to make informed decisions about their gender identity. It allows the patients and their parents or guardians time to determine which, if any, medical or surgical interventions are appropriate for their transition. The SOC 8 recommends puberty blockers be initiated at the first sign of sexual maturity, usually between Tanner stages 2 and 4. Tanner stages are a whole thing of like how you can measure how far along puberty you are. The SOC 8 also makes a distinction for the care of pre-pubertal patients, kids who haven't started puberty versus kids who have. And it specifically says that prior to starting puberty, it should only be social transition, changing what the child is wearing, changing their haircuts, referring to them by a different name and pronouns. That's it. No hormones, no surgeries, none of that stuff. Just, social transition.
Right.
So when you hear all these like crazy right-wing people who are like think about the kids and genital mutilation of children, that's not happening. The standard of healthcare for trans people specifically says that that's not a thing. That's not a thing that's happening. No. So, and in fact, gender-affirming hormone therapy is only recommended for use after the use of puberty blockers or the completion of puberty, like for adults.
Yep.
And specifically, it recommends estrogen therapy and anti-androgens like Cipro or Spiro for feminization for trans girls, and testosterone therapy, which is usually in the form of testosterone cypionate for trans boys. So all of they're not experimental chemicals. They're like naturally created hormones that our bodies naturally make.
Yep.
They're just for trans folks, they're not making the right ratio of them. So you're correcting that is all it is.
I know.
So,
isn't that a nice framing?
Gender-affirming surgical procedures, according to the SOC, is a very broad category, and it's only recommended for adults who properly understand the risks and benefits. Specifically, there's feminizing genital surgery, which includes orchiectomy, vaginoplasty, vulvoplasty. There's masculinizing genital surgery, including metoidioplasty and phalloplasty, hysterectomy, and oophorectomy, I believe I'm saying that right. Hysterectomy is the removal of the uterus, and oophorectomy is the removal of the ovaries. Those are usually performed at the same time as like a metoidioplasty or phalloplasty. Top surgery is often used to mean feminizing breast augmentation or masculinizing mastectomy. I don't believe the term top surgery is in the SOC 8.
Really?
It's just you commonly hear that in like common, conversation among the trans community.
Is bottom surgery in there? Because sometimes we say bottom surgery.
We do say bottom surgery. It's also not specifically, I don't believe that term is specifically used. It refers to all of these things. It just doesn't use that particular like colloquialism.
Sure.
So there are other gender-affirming surgeries that exist that the SOC touches on, including facial feminization, facial masculinization. It also talks about, this is for you, you'll know more about this than I will, but feminizing vocal or laryngeal surgery to raise vocal pitch and or decrease laryngeal prominence.
That's right.
I don't know a ton about that stuff. I imagine you do, because that touches directly your work.
Trachea shaves and all the voice surgeries.
I do know that those are considered the riskiest gender affirming procedures out there, I believe.
I will tell you, viewer, that it's important you don't go see a plastic surgeon for a treatment. Go see an ear, nose, and
Fair
throat
enough.
clinician. So, yeah.
The standard of care also does not state any specific combination of surgeries that any person should have. It doesn't specify any specific techniques that should be used.
Yep.
Instead, what it does is it primarily outlines guidelines that are appropriate for surgery preparation. Stuff that I think any healthcare provider would recommend for any surgery in general, like just making sure you fully, you're in a good headspace and you fully understand the risks and the benefits so that you can weigh those, informed consent kind of stuff. But specifically when it comes to the standard of care, there's the SOC 7, which is the version that you and I transitioned under.
Yep.
And then there's the newer SOC 8. So in the SOC 7, the older version, which there are a lot of healthcare providers that are still following the SOC 7, which is
Really?
fine. It's slightly more restrictive, but it's still, I think good guidelines. But the SOC 7 recommends that individuals undergo 1 year of hormone therapy and 1 to 2 years of living socially as their chosen gender.
Yep.
A comprehensive medical assessment, which, you have to do that for any surgery. You have to provide 2 letters from 2 different mental health professionals,
Yup.
both of which must have competencies in the assessment and diagnosis of transgender and gender diverse people. And one of those two must have a patient relationship of at least 1 year under the SOC 7.
Absolute bullshit.
Well, I think those are good guidelines. They're really restrictive.
I don't agree with the double therapy letter. Terrible.
That's fair. And that's the big thing that was changed in the SOC 8. So we'll get to that. But in general, I think those are pretty decent guidelines. It's just making sure that
you're trans enough.
I think that's how a lot of us view it. But
Better make sure you live as a woman for a year. God damn it.
Again, I think for us, it can feel like, they're just trying to make sure you're trans enough. But I think it's less about that. And it's more that, they want to make sure that you fully understand what it is you're doing. Right. Because it is when you get to things like HRT and surgery, there are certain things that are irreversible. A lot of HRT effects are fully reversible, but there are some that aren't, especially when it comes to testosterone, and when it comes to surgery, there's a lot that is pretty irreversible. It's important that you go into it knowing fully what you're getting yourself into. Sure. The SOC 8, which it's updated the guidelines to be a little bit more flexible. So it only requires 1 letter of assessment, again, from a healthcare professional who has competencies in the assessment and diagnosis of trans and gender diverse people is needed. So you don't need the 2 letters, you just need the 1. The SOC also states that psychological support, like a therapist, is a crucial aspect of gender affirming care.
Good.
Counseling and support is recommended in addition to any kind of medical or surgical treatment, so that the patient can assess their readiness and the understanding of their care and the unique stressors of transitioning, both social and physical, and that you can appropriately manage them throughout the treatment. And again, I think that's the part, the whole undergo HRT and live as your chosen gender for a year prior to surgery.
Right.
I think is to answer that, to make sure that you fully understand the unique stressors of transitioning and that, you don't go so far as to be irreversible if for some reason you need to back out either because, you're about to get fired or evicted or, disowned, or maybe you are that 0.1% that does experience genuine regret. Better to know now when you can reverse it versus, after the fact. So I think these are really good guidelines. And I think that anyone that looks at these is like, okay, so it is well thought out. It's not just gender affirming care handed out at the whims of any doctor because they don't want to be canceled, right? There are well thought out medical guidelines and procedures that go through very carefully to make sure that, the person who's getting this care understands fully what it is that they're
who's looking at these, right? Professionals and transgender people. Who's not looking at them and needs to look at them? Those who hate us.
Or people that don't necessarily hate us, but just don't have a reason to look into it, which is one of the reasons I do this podcast. That's why I wanted to walk through what the SOC guidelines are right here, right now.
Yeah.
For people who don't know, like my dad, who listens to this podcast regularly. So, hi, Dad. I think this is the kind of thing that we need to talk more about for that reason. So,
Right.
yeah, that's kind of the history of gender affirming care, and who knows where the future could go. I mean, we talked very briefly about there has not been a successful uterine transplant for trans women, and I think that could be very interesting to look into. I know that there are a ton of trans women who would love the option to be pregnant and carry a child to term. I've often thought about being a parent. I think in my case, I would, if I'm going to be a parent, I'd probably adopt, but I'd like the option.
I think you'd be a good parent.
Thank you. Also, something that could be very interesting in like this whole like research avenue is that I like to 3D print as a hobby.
I
so
do.
I'm always keeping up with like 3D printing news. And I remember years ago when I first started getting into 3D printing, they were also like newly studying like bioprinting, like 3D printing for medical use. And one of the ways that they do that is they will take an organ, like a donor organ that for whatever reason is not eligible for transplantation, but it's still relatively healthy and functioning.
Yeah, right.
And they turn it into what's called a cellular scaffold. And if there are any like medical researchers or experts on this topic, please email us and correct me everything I get wrong, because I'm sure I'm not doing the actual thing justice. But my understanding is that they more or less sort of like very carefully wash away all of the cells in the organ and leave just like the like skeleton of it that's made out of like collagen that like sort of creates like, I've seen pictures of these and they look like a ghostly shell version of the organ. And then they'll take stem cells from the recipient of the organ and introduce them onto the scaffold. And since there's already kind of this like blueprint of what the organ is supposed to be, the stem cells just kind of like fill in the gaps and recreate the organ, but they do so with the recipient's tissue. So you don't have to worry about like organ rejection or anything like that. And that's really cool.
That's the
but
future,
I wonder,
Danny.
right. And like they're successfully using this for recipients today. I think it's still in its like infancy. It's still considered like experimental, but like, organ transplant, like people who need like new livers and stuff are able to use this technique, which is really cool. But it gets me thinking about like the future. Like, is it possible for women who are born without ovaries? So that would include trans women, but also just like cis women who have like an intersex condition who are born without ovaries. Could you take an ovarian cell scaffold, introduce stem cells into that scaffold, and create functioning ovaries for that woman? So like you could use that for trans women potentially, but also like address infertility in women. And if that works for ovaries, then probably for testes too, I would assume. So you could use that for infertility for men potentially. Like who knows? And that could be cool. And like for trans women especially, the ovaries are the main source of production of estrogen. So could you create a functioning set of ovaries and implant those in a trans woman so that even if she doesn't want to get pregnant, even if she doesn't, get like a transplanted uterus or anything, she at least would not have to rely on hormone replacement therapy medications anymore, because now her body is producing the hormones that she's supposed to be producing.
Oh, that'd be nice. Yep.
That'd be like, it's that kind of stuff that I think about that gets me excited about like the future for gender affirming care. And I do believe there is a lab in one of the Nordic countries. I want to say Sweden, but I'm probably wrong. But I think that they are exploring like this concept. And I think they're exploring it not with trans women in mind, with like, cis women fertility is like the initial goal, but like they have been very open about like, if it works for cis women, it should work for trans women too. And like, that was something that they'd be, interested in exploring. So I think, and again, if there's someone that is an expert that, can correct me, please do. But I do think I heard that there is a laboratory in Europe somewhere that is already kind of exploring this. But like, how cool is that? Right? Like, it just, I know, it's really interesting. So anyway, I think that's all we got for the history of gender affirming care. Like we said at the top of this episode, this topic is like real broad and real massive, and it's always evolving. So there's a lot in going through this brief timeline. There's a lot that like I'm sure we glossed over. There's probably stuff that we missed that I just didn't find in my research when I was putting this episode together. So, if you know of something, please let us know. If you like this episode, if you're listening on YouTube, leave a like, subscribe, drop a comment. If you're listening on Spotify, you can leave a comment there too now. So please leave a comment there. Let us know what you thought of the episode. We'd love to hear from you. You can find more episodes wherever you get your podcasts or directly on our website at .fempodcast.com. If you really enjoy queer history and want to help preserve our stories, you can support us financially by supporting us on Patreon. If you have suggestions for other queer histories you'd like us to cover, especially if they're like small local histories from like your part of the world, we'd love hearing about those. Please send us an email on our website. Or if you are, for some reason, so inclined, you can send us real life paper mail to our P.O. box. The address is on our website as well. You can find that there. And we'd love to hear from you. But with that, this has been an episode. So thanks for listening. I'm Danielle Gonzalez.
And I'm Claire.
And we will catch you next episode to talk about Lily Elba.
Bye.